Okay. So I also have some disclosures. Okay, so we'll start with a question. The Sapien 3 frame, choose the correct statements. The Sapien 3 frame is made of platinum and iridium with gold welds. Sapien 3 valve leaflets are porcine pericardium. The outer diameter of the 29 millimeter Sapien 3 valve is 31 millimeters. The washing jet of the Sapien 3 can be confused with PI on the post-implant angio, and PI noticed on post-implant PPVI should be confirmed with ice, with all catheters and wires removed. Correct statements. Statement number 1, show of hands. Statement number 2. Statement number 3. Everyone sure about statement 3? Everyone sure? Statement number 4. The washing jet. I hope I didn't get anyone on the washing jet. That's good. And 5. Show of hands, correct statement? 5. Okay, 5 is correct. There's one correct one. The other ones are not correct. Okay, so when we look at the different valve therapies, Melody, bovine jugular vein, Cheatham platinum stent. That's John Cheatham, by the way. He's the Cheatham platinum stent. And Sapien, interesting, this is where we kind of started with Sapien pulmonic, which was the very first generation, which was actually no nose cone, valve crimped on balloon. And if you think things are difficult now, you should have tried that, because that didn't work very well. And then we, of course, evolved to the Retroflex 2 and then Retroflex 3. And now we have this system for a Sapien 3. The nice thing about the Sapien valve is it allows you to address very large bioprosthetic valves and conduits that, although are approachable with Melody, are more potentially difficult than Melody. This is what the valve used to look like, a stainless steel slotted tube stent with two sizes initially, 23 and 26. The access was about the size of a dime in diameter. We then moved to Sapien XT, and I'm just going to move along here just for the sake of time. Cobalt chromium, it's bovine pericardium. It's bovine pericardium with proprietary tissue treatment. And they moved to this system on this is of course an aortic valve, not designed as a pulmonary valve. And the issue is that they found that if you're going to mount a valve on a balloon, you're going to require a much larger access. So why not push the balloon out first, then push the valve on, then push the valve out, and then just kind of align it in the aorta to save profile. And the initial problems with the Sapien for the pulmonic system is that you're pulling the balloon against the leaflets oriented in a different way, and there was concern that this would be a problem in terms of leaflet integrity. And then benchtop testing was done, and it was determined that this was not the problem. This is the most recent iteration of this, the Sapien 3 valve, which is a cobalt chromium stent. It has a large upper frame, predominantly for coronary access on the aortic side, and a tissue skirt. What are you going to need for this procedure? Balloon wedge catheter. In adults, you're going to need some stiff wires. I know that people have tried in pediatrics to use left stiff wires with very big hearts and very large curves. If you don't have a stiff wire, this is not going to work very well. Something to take some pictures with, compliant balloons, non-compliant balloons, long sheaths, appropriate balloon stents, and Sapien valve. And I will tell you that the most difficult part of this procedure by far in the 31 millimeter valve, if you're going to stent it or a large conduit, is to actually do the pre-stent. The pre-stent on a 28 millimeter balloon is extremely difficult. You have to get a 16 French sheath up into the pulmonary artery, and that poses by far the greatest problem, technical challenge. Why do we pre-stent conduits? Well, we want to optimize it. We want to reduce the risk of conduit rupture, verify gradient reduction, reduce the risk of paravalvular leaks, and that's very specific to the Sapien valve because of its length, scaffolding and support, and facilitate valve delivery. And I want to go through a few of these quickly. This is a very heavily calcified conduit after a Ross operation. And really the question is, how do you balloon test this? This is quite a difficult thing to do because of the concern about rupture. We'll talk about that in a moment. In this case, because we knew the coronaries were far away, we actually put in a covered stent on a small balloon and then just kind of banged it up. And the reason why we use the covered stent is to avoid this situation, which is conduit rupture. Conduit rupture is fairly rare. And I assume most of you, when you're dilating these very calcified conduits up, you're going to go very, very slowly, measure the waist, and slowly ease it up, because if you want to have a catastrophe, the best thing to do is use a large balloon and bang something open, and then you take a small problem, make it a gigantic problem. In this particular case, we just bang this up with non-compliant balloons and then put in a valve. When we talk about conduit rupture, there's a number of series that have addressed this. U.S. Melody series, Philip Bonhoeffer series from Great Ormond Street, and Boston. Relatively uncommon problem. Not all require surgery. Some can be managed conservatively, some with covered stents. Reducing the risk, dilate up slowly, especially if you're very calcified, go slowly. Choose a balloon several millimeters larger than the waist on a compliant balloon, especially important if there's complex topography. It's sometimes very difficult in large conduits to precisely angiographically define the internal diameter of the conduit. A compliant balloon works very well, like an ASD sizing balloon. And certainly don't use the size of the surgical conduit as a size you should get to right away. Here's an example of me not listening to my own advice. This is a 24-year-old male, 18 months after a Ross procedure, and he's had some immunologic reaction to his conduit. And the waist is about 9 millimeters. I chose an 18 millimeter balloon, and I figured I would go very slowly because it's a 27 millimeter conduit. And you can see that as the balloon finishes dilating, we've lost this little part of it. This is a very soft dilation, really. So we took this picture afterwards. So we took this picture, and what do you think of this? Can you see this well enough? I think so. Any issue here? Or? Yeah, it just jumps. Once you've seen one, it kind of jumps right out at you, right? So this here is very abnormal. This is a problem. And actually, when you look to the AP with cranial, you can see that there's this. How sick was this person when this happened? Not very sick. Not very sick. So we were able actually to get a covered stent up. I was a little higher than I'd like, and so here I'm just checking the pressures in both PAs to make sure I'm happy, and there was actually no difference. And then basically we backed off and came back a few weeks later. I had the surgeons come over, and kind of everybody said, well, we prefer you don't smash it up with another big balloon at this point, even though there's a covered stent and it's not bleeding. Reduce the risk of paravalvular leak. This is something very specific to the Sapien valve. I'll just check my time here. That's not working anyways. Great. The Sapien valve is a short stent, so you may not get a 360-degree seal. So if you stent a large valve with a bare metal stent, and you put the valve in and you move, this is not like an aortic valve, and the reason why is because the S-shaped curve to get through the tricuspid valve and up is under a lot of strain. And if you inflate the valve partially, you may have variable success in repositioning. You can slip back and not be able to move forward, or vice versa. And so if you put in a bare stent and you're low and you miss the frame of the valve, you're going to leak through the top of the stent. If you put in a covered stent, you really have this runway that you establish, and you're pretty safe. You have more margin for error. And are you going to get away with this 95 times out of 100 by putting in a bare stent and doing it? Yeah, but 5 times you won't. And those 5 times you're going to have to redo. And this is a case of that I'm going to go through very quickly, but this is a little bit low. A second valve had to be put into this. Start with taking a good picture. We like to calibrate because our cath lab is Toshiba, and I think Toshiba cath labs are like their TVs, not very widely used. They're not one of the sponsors, by the way. Otherwise, they'd be awesome. That's a little Gallows humor. Take a dark picture if you can. A compliant balloon is very, very helpful to get this internal topography, so you want to make sure that you identify clearly where the area of the stenosis is, and especially if you're going to use a short valve, that you're going to be able to get it in the area of the stenosis, so you don't have to worry about stenting or fixing it up afterwards and you wish pinning leaflets, etc. And then you're going to do a formal, like the royal wedding, coronary evaluation. Conduit coronary contact doesn't predict compression, and a slightly more remote location doesn't rule out compression. Most patients should have a test inflation with the same size balloon, right? And we want to avoid things like this. I think if you have a death from a coronary compression in a pulmonary valve implant, you got yourself some trouble there. That's kind of a not acceptable thing. There's been a lot of discussion, a lot of teaching about that. Whoops, sorry about that. In the U.S. Melody trial, 4.4% of people were screened out because of coronary compression. I'll just make the point quickly from this paper from Circulation. And by the way, all the talks are going to be on our website, so you'll be able to access them if there's any particular reference that people are moving quickly for. 5% demonstrated coronary compression in this series. And the most likely thing to be anomalous is an LAD from the right sinus. So especially on guard, the right and the left can be compressed. You have to be aware of both. So you really have to be quite careful. Full-size balloon inflation, coronary injections don't work by intention to treat. If you're not sure, you got to move the camera around until you get a clear view of what's going on. There is a potential issue of stenting open a coronary ostium with a catheter. I think that's an uncommon problem, but certainly can happen. I'm sure people have experience with that. We like, sorry?
So which question, coronary compression. One of the issues is that obviously with heavily calcified homograph, and how do you measure coronary compression unless you use a big enough and a stiff enough non-compliant balloon? That's an issue, right?
Yeah, so I think basically the idea is you dilate up very slowly, and I think with any size balloon blown up, you can get some idea of your distance. Obviously, if you're way far remote, I think that's fine. As you get closer, you got to start making decisions, right? You don't want to have, the nightmare situation is you have a conduit rupture in a compressed situation, and then you're stuck. You have to fix, right? So we like to put in stents like this by exposing the distal part of the stent, opening up the end, engaging it into the lesion, take your head off inject the inflator or the syringe, pull back the rest of the sheath, and then finish the inflation. No matter what, whenever you put in large stents, and I'm sure you've been told this a million times, go slowly. A lot of things are fixable. You move fast, something slips out of position, you have no hope. You go slow, you have time to readjust. Very important to know your inventory, what stents you have, how much they shorten. This shouldn't be like a Gestalt thing. I think it should be kind of in tables unless you have 30-year experience. So in our cath lab, we have a binder where we have every stent we have, what the diameter, what they shrink to with whatever diameter, and so we can choose pretty precisely what we want to use. This is just completion of a stent. This is a stent called the Andra stent. I don't think it's available in the United States. This is especially helpful for large conduits. Because of its hybrid design, it actually locks into the wall. Some people will pre-stent very large conduits that are 28 millimeters, lock the stent in, let the heart grow into the stent to lock it in place if you're kind of just touching the wall, and then come back 3 months later and you can put a valve and a recovered stent inside that. This is a short stent. There's a case from another hospital. Short stent, there can be a lot of movement. It's extremely important when you put in stents to go slowly on the deployment. This is a kind of a rapid deployment in a short stent, and you see it just falls back. You go slow, you have a chance to readjust, pull on the wire, get it to come forward. This had to be kind of fixed up a bit. This is not the ideal situation. It makes your day much more difficult. Slow inflation is better. This is a very old case. This is the old delivery system. But the slower you go, the better and the more able you are. You have to use, having a stiff wire is extremely important. This is dextrocardia transposition. And you can see here that there's a lot of kind of curvature. Using a stiff wire, if you look at the lower panel, you can kind of, oh, sorry. I maybe missed, oh, here we go. So using the stiff wire, you can kind of separate the pusher, pull on the wire a bit, and then kind of just float it in over the wire. Very helpful technique when you get stuck. It's not all brute force with this. As a matter of fact, if you use brute force and you lose the wire, you've got quite a substantial problem on your hands. You're going to start the case over again. Advance the valve slowly. Don't lose the wire. There's a lot of options and maneuvers that you can use. I'm just getting to the end here. This is a short video about the 29 millimeter valve. This is done through a Glenn shunt in a 29 millimeter XT valve. So we actually stented from below and then delivered the valve from the top. This is in an era where we didn't think we could go from the groin because aligning the valve was the problem. We weren't sure that was actually safe. This is a large bare metal stent. At this time, Just fixing that up with a balloon. Pretty hard to find long balloons in big sizes. And then we can just hurry this up and just finish here, and it actually is a very nice result. The Compassion 3 trial is started in the U.S. Yeah, started in the U.S. looking at Sapien 3 for the pulmonic system. In summary, the Sapien valve is, I think, a very helpful tool in the armamentarium, especially for very large bioprosthetic valves. This is a procedure where I think you have to be careful. There can be a number of problems, and if you rip an iliac vein with a valve, then you're going to realize what true terror is. So you have to be careful and go very slowly and step by step. And I think your team really needs to understand this. It's not really a one-operator procedure. Thank you very much.
Question?
How often do you use RV pacing for these cases?
Never.
One case.
Even in natives?
One case. I think that, I think that if you kind of make an assessment that you really have a huge amount, usually what happens is things are so, under so much tension, like at least for the pre-stent, they don't really move a lot. I think, to be very honest, my kind of fear is if you don't pre-stent with a covered stent, and you really have to hit, you really have very little leeway. Like, for example, there's stenosis right at the top of the bioprosthetic valve, and you're worried you may miss it. Like, you may consider pacing in that situation. I do not like that approach, because I think although you can get it most of the time, there's going to be times where you're going to miss, and then it's going to be a second valve, or it embolizes, or something like that. That's why I am a very strong proponent of, for large things, pre-stent, covered stent, especially if the conduit's big, especially if the conduit's irregular. Because if you don't get that 360 seal with a short valve, Melody's covered the whole way, right? So it's easy to seal. Sapien, much more difficult to seal. You don't want to have a perivalvular leak and have to kind of worry about that and not have a way to fix that. I have to tell you that we pre-stent everything. I mean, Lee, you may want to make a comment, but I mean, we pre-stent everything with Sapien. Melody may be a different situation. I would also tell you that our experience in natives using Sapien is very, very small, right? Because mostly they're gigantic. In adults who have a transaxillary patch, they're enormous, right? So.